Hello, my name is Andrew Brunner. I am a medical oncologist at Massachusetts General Hospital in Boston, Massachusetts, USA.
Hi, I'm Lionel Ades. I'm a professor of hematology in Imetelstat in Paris.
Hi there. I'm Mikkael Sekeres. I'm Chief of the Division of Hematology and Professor of Medicine at the Sylvester Cancer Center, University of Miami.
We're here today to talk about our recent presentation over new advances in lower risk MDS and reporting on clinical trial outcomes here at the iwMDS in Lisbon, Portugal.
So I had the opportunity to present the results of a COMBOLA trial, that is a trial combining Luspatercept and ESA in a difficult to treat population. I mean, among patients with low risk MDS, having failed ESAs without ring sideroblast. And I've presented the first part of the trial with 24 patients that have been treated with the combination of the two drugs, and we were able to achieve 30% of a response that is quite nice indeed. And the trial is ongoing. We have a randomized part of the trial now that is ongoing, comparing Luspatercept as a single agent or the combination of Luspatercept in ESAs.
And I had the pleasure of talking about Imetelstat, which has recently been approved for the treatment of patients who have transfusion-dependent lower-risk MDS after they've been exposed to an ESA. And the question I was asked is, when do you give Imetelstat? Often we treat patients with lower risk MDS with erythropoiesis-stimulating agents, or ESAs, as a frontline therapy. We anticipate the response rate to ESAs is going to be somewhere in the range of about 15 to 40%, and naturally, patients who have lower risk MDS with lower baseline serum EPO levels and lower transfusion needs are more likely to respond to ESAs. Recently, we also had approval of the drug Luspatercept. Luspatercept can be used upfront for the treatment of lower risk MDS and also in the second line after patients have been exposed to an ESA. In the upfront setting, the transfusion independence response rate lasting 12 weeks or longer was approximately 60% for patients who received Luspatercept, compared to 30% for those who received an ESA. However, most of that response was driven by patients who have ring sideroblasts or an SF3B1 mutation. The response rates to patients who don't have one of those two conditions is about the same for an ESA or Luspatercept, and either can be used up front. In terms of sequencing, we then will consider use of the drug Imetelstat, which has a transfusion independence response rate of approximately 40% for patients with lower risk MDS who are transfusion dependent. And after that, we will often consider use of hypomethylating agents in truncated dosing regimens for patients with lower risk MDS.
We've had a lot of advances in how we manage lower risk MDS and the options that are available for patients, especially with those who have transfusion-dependent anemia. But one of the challenges that we faced in MDS is how we talk about it. And what do we understand as a benefit or as a meaningful outcome for a given patient population, particularly in clinical trials. And so while I was here at the meeting here in Lisbon, I had the opportunity to talk a little bit on standardizing the way that we report on clinical trials. Even for trials like low-risk MDS, sometimes it can be challenging to cross-compare the results because we use different language for what is a meaningful or a durable response, depending on the setting, the type of patient that we're dealing with, whether it's frontline or second line, and how long we want that transfusion independence period to be. Particularly in high-risk MDS, we use a lot of different definitions for what we think is a meaningful response. And sometimes it's very challenging to know, is this truly a promising compound, or do we have to think about this in the context of what we already have available? Is it really beating the standard of care? And so in order to try to improve the way we communicate with one another about meaningful compounds in MDS, as well as to try to advance the pipeline for new therapeutics, we are at this meeting trying to come up with some basic minimal criteria that we can use when we report on an MDS trial that, in addition to other more novel or newer endpoints, can ground us in what is a known meaningful endpoint so that we can communicate about, well, this drug might be meaningful for transfusion independence, or this drug has a certain complete remission rate, and that might be more comparable to what we know and what's approved in this disease. And so I'm hoping that after this meeting, we will, as a group, be able to come up with better unified language for ways that we can adapt trials in the future so that we can continue to advance new therapeutics in this pretty heterogeneous disease.